Good morning, everyone. Today's topic was part of a presentation I gave for our internal medicine residents. And so the content is intended for the generalist provider who will be caring for patients at the end of life and facing this particular symptom. And here's our outline. At the end, I hope you will be able to leave here with an improved understanding of what is death rattle, how our patients and families perceiving it, how it helps us in prognostication, and how it is best addressed. We'll start with the case. Your resident team is overseeing the medical care of a 54-year-old gentleman who was admitted to the hospital in pain crisis related to progression of a stage 4 pancreatic cancer. On exam, he only responds to pain by withdrawing. His facial expression displays a grimace. His breathing is in a Cheney-Stokes pattern. He has no palpable radial pulses. He has mottling up to his mid-shins, and his urine output was 32 cc's over the past 12 hours. Now, this is a very specific set of physical exam items, and I am intentionally commenting on breathing pattern, radial pulse, mottling, urine output, because these are some of the physical exam signs that help us in prognostication at end of life. Now, before I go on, I'd like you just to take a few moments to think to yourself, what is this man's prognosis based on these findings? So in collaboration with oncology, in your physical exam skills, you both prognosticate that he is very close to death, hours to a few short days. His family elects to transition him to hospice in the hospital after it's determined he is unsafe to transfer to a hospice facility closer to home. You are responsible for directing his comfort-focused care. You use a combination of fentanyl and haloperidol to help address the pain and agitation, and within an hour, your patient is resting comfortably in bed with family at his side, and you have done great work. Your shift is over, and you are signing out to the night intern, and you think to yourself, is there anything else that I could have done for my patient or for my colleague? Inevitable. 2 a.m., the nurse pages your night intern. Family upset. Breathing changed. Scopolamine patch? Please come to the bedside. And here's another chance for you as a resident in training to reflect silently to yourself, how might I address this issue if I'm the night intern? What could I have done differently to prevent this distress if I was on the day team? I'll give you just a moment or two to think silently. When you arrive, your patient is having wet and gurgling breathing audible from the hallway. Family is distressed by what they're hearing, and they ask you, is he drowning? So let's discuss this exam finding called death rattle, and then at the very end, we will circle back to the case. Etiology. Now this is literally a death rattle, and it sits in this display case at my home office. A gift from my colleagues that shows how dark humor can be sometimes in medicine, and yet also how therapeutic humor can be for us to cope and get through our days. You can imagine that anything in the final hours to days of life is very difficult to study. That time for family is sensitive and precious and short, and enrolling in a study with a placebo arm that risks untreated potential suffering is ethically challenging. And so there is not as much literature here as we would desire to have. But here's what we think we know, or what the literature we do have tells us. Noisy breathing at end of life, or death rattle, is speculated to be turbulence of air over bronchial and pharyngeal secretions, believed to be the result of a patient either being too weak or more commonly too somnolent to clear these secretions. And some experts in our field refer to death rattle as a natural occurrence at end of life. It's not believed to be due to the lungs filling up with fluid, nor the patient drowning, as some family do fear. though there are disease processes where accumulation of fluid in the lungs can cause similar sounds. And that's what we called pseudo-death rattle, which includes the obvious players like pulmonary hemorrhage or massive aspiration or flash pulmonary edema. The truth is that these patients are unconscious, and we cannot ask them if it's distressing to them. And so, to some degree, it's assumed that since this is primarily a sound in a population of patients who are unconscious, that it's unlikely, or hopefully unlikely, causing suffering. But we don't know that with certainty. A study published in 2013 attempted to test this and showed that there was no association between the severity of death rattle and the respiratory distress in this particular prospective two-armed observational study of 71 patients at the end of life. And so most palliative medicine specialists I know focus their attention on how they can treat the family that do have to experience it. And lastly, it's common, with studies showing that there's a prevalence of 25% on the low end to greater than 90% on the high end in patients at end of life. Perception. There are a multitude of studies that have measured how family members perceive this symptom. In pooling them together, there are some common themes. The first is about distress. While more than half of family do find the symptom of death rattle to be distressing, not everyone does, which shows that family approach these situations with different understandings and different past experiences. And here I've taken some excerpts from the semi-structured interviews with family. And these first two bullet points are from family themselves. And it's not just distressing to family, right? It impacts everyone: nurses, physicians, housekeepers, chaplains, volunteers, basically anyone involved in the care. Take, for example, this third quote from a bedside nurse, which says, "It goes back to the question about who we are treating, really, doesn't it? Is it actually us as nurses that we're doing it for?" The second is about our role in helping family to be prepared. Family who were not educated in anticipating the symptom were much more likely to report suffering, which is not surprising. It informs us on why it is so critical to talk to family about expecting this before it starts. And lastly, we have preparation. For some family, this can be useful. Seeing these exam changes helps them to recognize how close the end is so they can prepare themselves. Prognostication. We struggle with prognostication in general. And part of this is a reflection of just how diverse and infinitely complex people are, and how plugging an individual into an equation is just never going to be perfect. And the literature shows just how difficult this is. In a prospective cohort study published in 2000, they measured the prognostic accuracy of 365 physicians across the medical specialties who were enrolling their patients in hospice in the Chicago area. And the results of this particular study show us that physicians overall tend to overestimate prognosis. And in this particular study, they overestimated by a factor of 5 overall. And interestingly, it showed that the longer a provider knew a patient, the less accurate they were, which feels both obvious and counterintuitive at the same time. And I suspect what is likely going on there is that our bias starts to enter into the equation as we form a relationship over time with someone. And you might think, well, maybe people who do this for a living are better at it. What about palliative care specialists? Well, there are no head-to-head studies that directly compare palliative care to other specialists, but there is literature to show that we too tend to overestimate. But there's hope for us all. The one finding that we can look forward to and hang our hat on as we advance in our experience is that physicians in the final quartile of their careers were the most accurate at prognostication. So let's look specifically at how death rattle helps us in that prognostication. In 2014, this prospective observational study came out of MD Anderson in Texas and Barretos Cancer Hospital in Brazil. Its intention was to identify physical exam signs that could be helpful in our prognostication at end of life. And there are some limitations to this study. It was conducted only in cancer patients, and secondarily, it was performed in a palliative care inpatient unit within a hospital, which means we're selecting for patients with high symptom burden needing admission. And here I have the first of two of my favorite images from this study, which plots out the median time of onset of these 10 findings. This table points to death rattle being a late exam finding present in the final hours to short days. And second, we have here a nice grouping of other exam findings that may aid us in helping family decide if it's safe to transfer or if it's time to call family to visit. And when we look at the reliability of these same exam findings, we see that almost across the board, and in particular for death rattle, that they have a very poor sensitivity and a very high specificity, indicating that if death rattle is present, then it is highly predictive and highly useful for you as a clinician to feel confident that your patient is nearing end of life. And if it's not present, then it really does not tell you much. It's only useful when it is present. Though unrelated to today's talk, if you are interested in reading more about other physical exam findings at end of life, the same group out of MD Anderson expanded on the previous study. They looked at 10, and here they looked at an additional 52 physical signs, and those physical signs' relation to prognostication. Interestingly, the most helpful signs were neurologic. So, treatment. Should we use a medication? We are prescribers, that's our natural inclination, and we have anticholinergic drugs available to us, which are intended to block the parasympathetic system, leading to our goal of decreased secretions. However, muscarinic receptors are present in every tissue, and there are potential side effects like agitation, delirium, dry mouth, constipation, but it's unknown if these symptoms are being perceived by patients who are unconscious and can't be asked about those experiences. The anticholinergics available to us are divided into two categories, and those categories are clinically significant and worth knowing. The two categories are based on how many carbon bonds, whether it's 4 or 3, are attached to a particular nitrogen atom in the molecular structure, hence the quaternary, tertiary names. And the quaternary category, which is just glycopyrrolate here in the US, has much less blood-brain barrier penetration, and therefore, theoretically, less CNS side effects. And so this ends up being one of my go-to medications if I'm going to choose one at all. So let's take a look at how effective these drugs are. An original Cochrane review was completed in 2008, revised in 2012, further reviewed again in 2017. Only 4 total studies were rigorous enough to meet the inclusion criteria. So you can see how sparse, high-quality evidence is in this population. All 4 were randomized trials, but only 1 was placebo-controlled. And the sizes were fairly small, with the 4 studies having participants of 10, 13, 31, and 333. And all 4 studies were completed only in cancer patients. The conclusions drawn from this were based on 1 of those 4 studies with 333 participants that compared the efficacy of atropine to scopolamine to glycopyrrolate. All 3 were found to have similar effectiveness, and therefore there is no recommendation to choose one over the other based solely on efficacy. Secondly, there's no current evidence supporting that these medications were any better than placebo. Unfortunately, only 1 of the randomized trials from 2002 was placebo-controlled, with only a measly 31 patients, and yet it showed no statistical difference between glycopyrrolate and placebo. And finally, we're left with a word of caution. Hearing death rattle can be distressing to us, to families. And so obviously there is a compulsion to do something. But with no current evidence showing medications have benefits, and with potential risk of harm, we need to be cautious with these medications. If we do use one and it's not helping, then we should deprescribe. This is interesting. I stumbled upon this study about a year ago. This is a randomized trial from Italy in 2018 that tested a hypothesis that we were starting treatment of death rattle too late. It randomized patients into two categories. It was treating death rattle after it starts, which is the current practice, or prophylactically, before it starts. And the group that was treated after symptoms arose had a prevalence of death rattle of about 60%. Compare that to the group that was treated prophylactically, which was less than 6%. And so this builds upon the existing concerns that perhaps the reason why these medications are not effective is that they don't eliminate the secretions already present and only impact production of new secretions. This has not made it into everyday practice. I don't treat prophylactically. I don't see people treating prophylactically, but it may be something we hear about more in the future. So what should we do? What is the best practice? There are a handful of simple techniques available, but the single most important recommendation for this population all centers around education of family, sharing with them what they will see before it starts. And here's how that might look. So we come back to the original case and we see that there was perhaps a missed opportunity here. During the initial assessment, there was a chance for us to prepare family for what they might see before it starts, before we hand off the case to the night intern. And here is one of many ways that you can talk to families about this. Some families during this time, they want to know a little bit about what to expect and what changes they will see. Would it be helpful if I shared that with you? Which might be followed up with, it's normal for people in this condition to have changes in their breathing. Sometimes it can sound wet, loud, sometimes like snoring. We believe that this is just small amounts of fluid in the airway, that they are not swallowing now that they're so weak. It's just a sound. We believe it is mostly distressing to us and not so much for the patient themselves. And if it starts, I will have the nurse use some techniques to help reposition and help to drain some of the fluid. And if family really are insistent on trying a medication, it's okay to give it a trial and reassess, being aware and being observant for possible side effects. And so you might say something along the lines of, I typically try to avoid medications initially because when they're studied, they really haven't been found to be very helpful. However, if our techniques are not working, we can try a medication and see if it helps. And so my colleagues that work in a variety of different residential hospice facilities throughout the Milwaukee area are really positioned to see this more so than I. My role mostly is in goals of care conversations. And so I picked a few of their brains to see if their professional experiences matched my own experiences and matched the literature. And we see here that it does. Here are some of their shared experiences. Education of loved ones is the best approach, if possible, before they see the symptoms. We spend a lot of time educating the family. Best managed with education of the loved ones at the bedside. And so you can see all of these focus in some way on the theme of education.